folks joining us today are really national public health and equity leaders, and they're going to be able to share a lot of strategies with you all on how to grow your organizational capacity to advance equity and really harness the power of your equity staff. So many of you are bringing on equity staff for the first time or growing your robust equity team. So I'm so excited to have these folks in our space today to share with you some of their lessons learned and strategies for building their own equity capacity in their departments and in their jurisdictions. So with that, I'm just going to briefly introduce our three guest speakers today. And they will also have a chance to give you some brief presentations, so they'll be able to dive a little bit deeper into who they are. But just briefly, I want to welcome Dr. Analilia Garcia, who has been a great friend to the Alliance, has also supported us in a lot of our work around embedding equity in the Emergency Operations Center. Dr. Garcia provides leadership and strategic direction for the planning, research, coordination, facilitation, implementing, and management of a diverse portfolio of department and county-wide public health initiatives with a focus on racial and health equity. She is the senior manager for the senior racial and health equity manager for Santa Clara County Department of Public Health. Dr. Garcia possesses over 22 years of experience in the nonprofit, academic, and government sectors. And she received her bachelor's degree from the University of California in Santa Barbara, her master's of public health from San Jose State, and her doctorate in public health from the University of California, Berkeley. So welcome, Analilia. It's so great to see you again, and so excited to learn more from you today. I also want to introduce Megan McClaire, who is the Deputy Director for Los Angeles County Department of Public Health and one of our collaborative members. Megan has previously served as the Chief of Staff for the Los Angeles Department of Public Health. She oversees the Operations Support Bureau, the Office of Communications and Public Affairs, the Center of Health Equity and Office of Planning, in order to ensure that departmental, programmatic, and operational efforts are rooted in community engagement and cross-sector collaboration to address health equity issues impacting county residents. So welcome, Megan. And then last but not least, we have Benicio Gonzales joining us as the Director of the Center for Health Equity for the City of Louisville Department of Public Health. And T began working for the Center for Health Equity in 2010 to coordinate the department's racial healing and equity initiative. T supports the department's strategy to deepen its focus on the root causes of health through authentic community engagement, strategic partnerships, and addressing data gaps and challenges. So welcome, T, all the way from Louisville. One of the great benefits of a virtual convening space is we can invite national leaders and leaders throughout the state to join us in the space today. So wonderful to have all of you here. So I have asked our panelists to provide a brief presentation so all of you can actually learn a little bit more about their equity journey. So I've asked them to provide a brief presentation describing their equity journey, the strategies they've used to develop their capacity, and some of the work they're engaging in now with their community. So Analilia, would you mind starting? And I think you mentioned you'd like me to pull up your slides, correct?
I can do my slides,
okay.
If that's okay with you. Do you want to continue? Yes, let's make sure it works. Can you see my slides?
I can, yes.
Okay, and just a really quick time check, just 10 minutes, right?
Yes, you can have a little bit more than that if you need it.
Okay, awesome. Well, good afternoon, everyone. My name is Analilia Garcia, pronouns she, her, ella. I am the Racial and Health Equity Senior Manager at the Public Health Department. I am really excited to be sharing virtual space with all of you, and I also look forward to learning from my fellow panelists about the amazing work that they are doing. I always take these opportunities to not only share what we've done, but to also glean just lessons and examples from others as we are all embarking on just a common agenda of advancing racial equity from within a government sector. So just want to ground you in our work at Public Health. In 2015, the Public Health Department made a very explicit commitment to not only reaffirm our commitment to health equity, but to call out race. We were at that time in our pursuit of public health accreditation, as many local health departments were pre-COVID. And I was facilitating that process. And just by way of reference, I was fairly new to the department at that time. I spent about 10 years at a community health clinic in Oakland in the San Francisco Bay Area, and had spent a lot of time as a community organizer, working on a wide range of social justice issues. So when I landed at public health, I would often ask, so what is our health equity commitment? What is our racial equity commitment? And I used to get a variety of responses. We didn't have a uniformed approach, and it was through our pursuit of public health accreditation that it was an opportunity to re-examine our values, re-examine the work that we do as a department. And there was this underlying assumption that of course we do racial equity, of course we do health equity. It is in our DNA. It is what we do at public health, but it had not been explicitly stated. So in 2015, we went through a very robust and accelerated process of developing our strategic plan. And in that plan, we actually named advancing racial and health equity as a core strategic priority in our strategic plan. But mind you, in 2015, when we did that, we had no idea how we were going to do the work. We just knew it was a moral imperative and something that we needed to do as a department. What happened as a result is that because we named it in our strategic plan as a strategic priority, we were then able to resource a position, my position, to begin to do the work. And at the end of 2015, I was at a Bar High meeting, Bay Area Regional Health and Equities Initiative here in the Bay Area. And I met Julie Nelson, who was representing GARE, the Government Alliance on Race and Equity, who was introducing this concept of participating in a year-long training program to develop the infrastructure to do this work. So it is there where our story actually begins, is when I came back from that meeting. I'm going to let someone get into the room. I'm being asked. Someone's in the waiting room. I came back from that meeting and I told our leadership, our public health director, Dr. Sarah Cody, our / health officer, our executive team, I said, we named it in our strategic plan. We don't know how we're going to do this work. I just learned about GARE. They're coming to the Bay Area. They are looking for participants. I think we need to join this movement. It's a national movement. It's an opportunity for us to really gain the resource and the tools and the networks to really do this work to fidelity, to do this work to scale. So we joined the 2016, the first learning year here in the San Francisco Bay Area of the Government Alliance on Race and Equity. And I can quite frankly tell you, we have not looked back, only forward, and joined a national movement of government agencies working to advance and govern for racial equity. And for us at Public Health, that was really the turning point in terms of the work that we were doing. What started at Public Health, we are a department of 460 people within a county of 22,000 people. So I've always felt like the little engine that could going up that hill, a very tiny department in this really large ecosystem that really oversees within a county of a population of 2 million. And through GARE, we were normalizing conversations about race, building out our own infrastructure, which I will provide you more examples about. But really what was the instrumental factor in all of this was the mobilizing and the organizing that we did at Public Health by inviting other departments from across our county to partake, to join in this movement. And, for me personally, leading this work from the Public Health Department, that has been a critical tactic in just working across our county. So we embedded the GARE's national best practice, their theory of change, their framework of normalizing conversations about race, organizing a solid infrastructure, and operationalizing this work. And we have essentially taken that framework, and it's actually a framework that we've used to organize our strategic plan, our racial and health equity action plan. And under Normalize, I established the Racial and Health Equity Learning Institute. And this is a train-the-trainer program at Public Health. I recruited 30 individuals to train across our department, across 7 modules. The people that you see on the left, Charisse and Ricardo, were 2 individuals in our department who said, hey, I want to show up in this space. I have a passion for social justice. So what I did is I went across our department and I met with different programs and I invited them on this journey. It was really important that my message was clear and I met people where they were at to invite them to partake in this brand new training program to normalize conversations about race. Through this training program, we actually developed 7 modules: an introduction to racial and health equity. We adapted the GARE Structural Racism 101, their 2-day program, for our department. But for us, it was really important to not go out the doors with structural racism, that 2-day program, but to really start with why. Why is this important to public health? Why are we doing this work? And the how are we going to do it and with whom? So the 7 modules are an opportunity to normalize those conversations across a wide range of topics, which include cultural humility, LGBTQ health, applications of racial equity tools, community engagement. All of these modules have been adapted and designed by our teams with our community partners. And I really want to stress that this is not about doing onto community. We first went inward to really organize our own home. And as we were doing that, recognizing that it was really important to be working with our partners outside of the system, especially partners and communities that we're trying to positively impact through our work. Critical to our framework has been to organize the department, organize our system, and work in partnership with our community. We've established a racial and health equity committee, evaluation, training, and workforce equity action teams, and also established a countywide racial equity steering committee, as well as racial equity efforts in partnerships with communities in East San Jose, as one example, through the East San Jose Peace Partnership. We've also operationalized the work through the establishment of our strategic plan, a racial equity action plan, assessments tools, just like the organizational assessments, to better understand where we are along a continuum, to understand our practices and our procedures. We've actually undergone a wide range of trainings focused on equity-centered results-based accountability to really not only quantify and qualify how much is being done and where it's being done, but to really, at the end of the day, ask ourselves, is anyone better off as a result of this work? And have actually also operationalized racial equity tools, have used the budget equity tool in our own practice, and is now being used countywide, by the way, through which is a huge milestone for us. Last year, in the thick of the pandemic, this is a tool that has now been incorporated in our formal budget process, and it all started at Public Health with Public Health. And I can't end my presentation without talking about the instrumental work that we did pre-COVID between 2015 and 2019, how important that work was. That is Dr. Sarah Cody on the left. I remember in the thick of the pandemic, go back to March 16, 2020, the first shelter-in-place order that was in effect here in the county of Santa Clara. 2 weeks later, I was working at the EOC, and Dr. Cody said to me, I'm really concerned about our most vulnerable communities, really concerned about the impact of shelter in place, really concerned about the impact of COVID. Can we please bring our community partners together? I sent out an email on a Friday night, gloomy Friday night, and to our community partners. And by Sunday night, we had over 100 people that showed up and stood in solidarity with us and said to Dr. Cody and to our racial and health equity team, how can we show up with you? How can we work with you? And to this day, continue to be a critical partner. But I have to say, it's really attributed to the early just commitment that we made as a public health department to be data-driven, to be community-centered, and that has shown up in our COVID response. As you can see on the screen, we've embedded equity across the COVID continuum, from outreach, engagement, communication, and all of the operations to address the very real fear and mistrust that exist in communities of color that have been disproportionately impacted by COVID, and inequities have been exacerbated because of COVID. So these are just some examples of the work that we've done. We've done a wide range of things, and all of it has been really community-centered, data-driven. But I have to say, these partnerships were in existence before COVID. And I have to emphasize that. And I've always said that when COVID is done and we are in a different place, in a different space, I want my partnerships to be stronger than ever, because that is really at the core of what we do and the values that we are operationalizing through the work that we do here. I've also established a racial equity learning academy across our entire county. Just like we were dealing with the crisis of COVID, we were also dealing with the racial unrest, the murder of George Floyd, and all of that coming together in our county and across the nation. The racial unrest and the Black Lives Matter movement and the countless lives that we've lost to police brutality, systemic racism, there was a call for more. So I took what we built in public health, and as I was combating the pandemic, also working across our system to normalize conversations about race and establish an infrastructure to operationalize this work. What we have looking forward, this was my team, 2018 to 2020. It was only me and my health planning specialist, the fabulous Amber. And this is what my team looks like for 2022. Really, what COVID has done is really created an opportunity and now looking to not only continue to address the immediacy of the COVID impact, the COVID inequities, but also looking to work with our partners to address the social determinants of health, really center recovery, resiliency, and healing in this work. So we have a long way to go, but I have to say that the early learnings, early lessons, and the partnerships we've built both inside of the system and outside have been truly instrumental in the work that we've done to date, and we could not have done what we have done without that. So I will pause there.
Thank you so much, Analilia. And we will have time at the end for questions for all the panelists. I hope you all are jotting down your questions. You can put them in the chat or send them to me directly as they're coming up for you. I see Michael put sort of a question point in the chat. That's great. I took note of that as well. I'm always so impressed by just everything that you've been able to do in Santa Clara County. I know there's some great tools too, like your budget equity tool that we'll share with folks after this. So thank you so much for sharing. And I'm sure a lot of folks in this line can also relate to that image of your 1.5 person equity office that's now grown to a full team. And so I know a lot of folks are in a similar place. So it's so great to see. Megan, I will pull up your slides now. Give me 1 second.
Thanks so much for driving. Zoom is not friendly on our network. And it's good afternoon, everyone. It's really great to connect with folks and really great honor to be participating with our panelists. And I share with Analilia of the personal connection in that having come to public health as a community organizer on environmental justice and healthcare access issues, and really wanting to work within this system to make sure that we're serving everyone. So as Marley already shared, my name is Megan McClare. I'm the Chief Deputy Director of the Department of Public Health in Los Angeles County. You can go to the next slide. And today I'm just going to quickly talk through just introducing you to the center, the process that got us established, the role of the Center of Health Equity within this department, pre-pandemic, during, and then what we foresee doing in the road ahead. Next slide. I guess you can go 2 forward. All right, so I always put this in front of our staff as a reminder, and I'll share this with you as all. And one shout out a couple of our colleagues that are here, Scott Chan, who is our acting director for the Center for Health Equity, Monica Roldan, who serves on my team, Dr. Rashmi Shagiri, who's our lead of the data team, and then also Tiffany Romo, who is not with the Center for Health Equity, but was a founding member and would be remiss if I didn't acknowledge that. But, you know, I present this to our workforce and just to acknowledge that I think our work around creating an anti-racist, equitable organization really is a learning journey for us as a department and for us as an individual. As a county, we had embarked in 2017 on an implicit bias and cultural competency effort where all department leadership had to engage in a training opportunity and make organizational commitments, but acknowledge that we bring our experiences, our beliefs into the system with which we do this work. And if we aren't able to acknowledge that we might have bias in how we interact, we won't actually be able to create the structural changes that we'd like to embark on. Additionally, we have a labor partnership called Just Culture around creating a fair and kind workplace. This is what I consider to be our internal commitment around equity. How do we actually address adverse events within the workplace that creates a place with which people can feel comfortable in sharing what transpired. We come from a place of learning, and that we challenge the power dynamics in a hierarchical organization. We have the Center for Health Equity, which was established via a board motion in 2017. And then we have the Anti-Racism, Diversity, and Inclusion, which is a new addition to our county infrastructure. It was established in 2020 in response to the, I think as Analilia had noted, to the public murder of George Floyd, Tony McDade, Breonna Taylor, and countless others at the hands of government-sanctioned violence. And so really trying to create a place where we can address anti-racism. And all of this requires one, capacity building, but understanding that, you know, you walk away from a training, you need to be able to have continuous opportunities to engage in that work, opportunities to engage in meaningful discussion, and finding opportunities to support each other on this journey. Next slide. And you can go next one. So the Center for Health Equity in 2017 was established, as I noted, via board motion. We started with actually only 4 approved positions. All had to be borrowed or stolen from other units within the department. We were able to build up to 10, and then through curtailments and whatnot, we actually currently are functioning with 4 permanent staff people. There's a team that works on data and policy, which is really in deep partnership with the Chief Science Office, which is represented in this space today, and trying to, one, make sure that we're disaggregating data that's representative of the communities that we serve, that we know that there's gaps in data. So how do we really elevate, individual experiences and qualitative data to address that issue? And most importantly, that we contextualize this by the social drivers that drive those inequities. It's one to look at outcomes, but really, how do we really talk about what are the inputs that drive those outcomes? Partnership and engagement, we can't do this work unless we actually are working informed and directed by the communities that we serve. And so in that, we really work to support programs and identifying those collaborative opportunities. We elevate best practices for other programs that might have figured out this work. And then developing, I think organizational shifts and changes, whether it's stipend programs or training opportunities or establishing policies that really facilitate the engagement and collaboration we want to see across the entire department. And then operation support and workforce development. And this is kind of where I get most excited, although it's very administrative, but if we really are going to transform our systems, we really have to figure out what are the barriers for programs in doing so. What does our contracting look like? What does hiring facilitate? What does it mean to actually make resource investments that drive in our equity priorities? So really trying to develop the framework and providing programs with the tools in order to do that evaluation. Next slide. So when we embarked on the establishment of the Center for Health Equity, we did a few different rounds of community engagement. One was when we started it, we went through a broader visioning exercise, reaching out to, various, it was by supervisorial district, which has its limit, and that was a lesson learned, really to figure out what do folks want to see? What role do they want the center to play? How do they want to advance equity within their communities? And then we did another round when we went to establishing the center, the strategic plan. We identified those 3 major buckets of work. One to address, regional specificity, others to address kind of population, those that might not be regionally identified, but, demographic populations that we might have missed in the last round of input. That meant LGBTQ plus residents, working with Indigenous and Native American communities, people that are working towards disability rights, but really trying to do a series of launch sessions, having, listening sessions to get people's feedback, going through an iterative process. We also posted our strategic plan online that allowed people for the opportunity to give us input, and then went through another iteration of edits for that plan. You can go to the next slide. And then this is just some of the pictures from those conversations. And so there's a lot of feedback, so I'll try to keep it tight into 5 major categories. But I think where people wanted to see policies and system change is not just focusing on health outcome, but understanding what are kind of the social drivers. In particular, pursuing issues related to housing, immigration, education. The ability to make data that's useful and inclusive of the communities that we represent. There's a big push for us to work on data disaggregation, particularly around API communities, but also making sure that they have access to that data as well. One of the things that the Chief Science Office has been able to do is create data through our community profiles and make that accessible for people to use at their own discretion. Building, public, private, and community partnerships. So really making sure that that's fortified in all the work that we do. I think, one, it also is an ask for us to create shared capacity enhancing opportunities. So as we develop resources and investments in our department to learning alongside our partners as well is really important to that. And there are certain areas with which we need to expand partnerships where they might be very popular, program specific, that we want to make sure that we're reaching everyone. Inclusive hiring practices and training. County is very hard to get into. How do we really create clearer pathways? Also, how do we invest in lower barrier entry points, whether it be community health worker opportunities, identifying where we actually can promote retention and recruitment within our department and outside. And then last but not least, making sure that we're accountable, being transparent about our metrics, being transparent about the progress that we're making, and being clear about the impact that we want to make in our communities. Next slide. Another thing that happened parallel with this is that we have a community and prevention task force. It's a body of 25 community residents who really help to advise us towards our equity goals. And they had adopted a set of principles of equity for their task force. And we actually adopted this as a department. And so as we embark on a series of different, changes, or as we went to reflect in the strategic plan, we wanted to ensure that these principles were, one, adopted by us as an organization, but that also were represented in any of the strategies that we moved to implement. Next slide. And so the center has 5 key focus areas, 3 that are focused directly on health related issues, infant mortality, sexually transmitted infections, and exposures to environmental hazards. And then 2 are focused as healthy neighborhoods. So our Center for Health Equity actually is a part of a health Alliance for Health Integration, representative health services and mental health. Healthy Neighborhoods is a regionally based set of coalitions. I believe they have 17 in the county currently, where they kind of serves towards a kind of a provider coordination network. And the goal for these coalition spaces is actually to thinking more upstream around what are the drivers of some of these health inequities. Are there other issues that actually commingle with mental health issues, and how do we actually get some of that coalition space to start thinking towards broader social determinants of health. And then last but not least, cultural and linguistic inclusion and responsiveness, which doesn't sound very inclusive as I say it, but I will say that that's our language justice commitment, and really ensuring it's beyond just translating things towards, the threshold language, which is its own barrier, but really ensuring that how we communicate resonates with the cultural and language needs of the communities we're trying to reach. Next slide. And so when we look at the strategy, so regardless of the health issue, we made a commitment in the 5 years, and we're kind of looking at 2023 is when the plan is due for an update. And so, regardless of what we've elevated within that plan, I think across our entire department, we're committed to these strategies. Increasing our organizational capacity to engage in sustained equity work. That includes training, ongoing support, and resource investments that ensure that equity is embedded everywhere. Making sure that community voices are amplified in every part of our work, and that making sure that we're not reinforcing negative narratives, but we're really lifting up the authentic narratives and needs of the community. So ensuring that we're making action happen. Building and supporting community capacity, so capacity enhancing opportunities. And this really gets to resource investments. This gets to community engagement, but making sure that we are part of a broader ecology and system, and our strategies need to reflect that. Forging partnerships, traditional and non-traditional, to really make sure that we're addressing equitable health outcomes, and realigning our current resources. And this is really important for us to say, because now in COVID, there's more money around equity work, but before this happened, it didn't exist. And so the conversations we were having within our department is that we had to shift towards equity with the resources that we had available. And so it didn't mean it was coming with a grant. It meant that we had to make the hard decisions to ensure that we're reaching those that are most impacted by the health issues. Next slide. And go to the next one. So this is part of the implicit bias and cultural competency commitment, and we've engaged we made these commitments, and wanted to give a little bit of update on our progress, and I'm monitoring my time because I don't want to go too late. But really, this was increasing our contracts to underrepresented businesses. And so one of the things that we did, which feels like it's a small win, but it's a huge win administratively, was establishing a community engagement master agreement list. So in our county, it takes 40 to 50 hours to actually submit to an application to be a vendor. And you have to do that for every single one of our departments. It doesn't translate. So if you wanted to work with public health, you have to do a separate one for Parks and Rec. So we led an effort with 13 other departments to create a master agreement list, all for individuals that are committed to community engagement, and recognizing that CBO partners are probably better at doing this than we are, to create a master agreement list that built a bench so that folks can actually only apply one time and be able to actually support a series of different departments, a dozen plus departments across the county. Additionally, trying to find out every little loophole within an administrative process. Fiscal intermediary has been like the game saver throughout this entire pandemic. Finding a CBO partner that kind of knows how the government contracting works, is able to absorb those funds and then administer them to CBOs to help alleviate the burden on CBOs that we're investing, particularly during this pandemic, to really move fast and try to work directly with them to address barriers to reporting and spend down issues. Next slide. Enhance consumer engagement. So making sure that this is county speak, not public health speak, but making sure that we really are getting qualitative, meaningful feedback, not just to check in the box around how we're providing our services. So one of the strategies within the Center for Health Equity pre-pandemic was the establishment of a data advisory committee that they said we brought data projects, health impact assessments, and different topics to their review, and they gave us insights on how to improve. And we also drafted a departmental community engagement policy, which basically set the expectation that regardless whether you're writing an evaluation, you're doing a new program, you're curtailing services, you're making any changes, that there's some type of community engagement process. And we started that, and then the pandemic happened, which will be my next slide. You know, at the peak of the pandemic, we had 80% of our workforce completely absorbed, you know, in being redeployed. Our Center for Health Equity team had to go into liaison functions, supporting constituent concerns and complaints. And then, you know, but we really wanted to, I think to Analilia's point, is that the foundation of our work before the pandemic really centered health equity. We were really focused on, you know, essential workers, focused on, you know, how we could contract equitably. A lot of those conversations set that stage. And so now that we have additional grant funds available, we've been able to bring on 7 additional staff. And in that, we are expanding and extending our system navigation and community outreach infrastructure to reach priority communities. So that includes, you know, making sure that not just health issues, but I need housing, I need, you know, food security, I need mental health supports, that we're investing CBOs to provide that work. We've also invested very heavily in a community health worker outreach initiative. Shout out to Tiffany Romo, who was on this call, who's really provided tremendous leadership in that effort. Improving data collection and disaggregation. So this actually funding is allowing us to do what we didn't have the resources to do. Dr. Shakiri, who's here, has been providing tremendous leadership on that front, and we'll be reestablishing our data advisory committee again to focus on these efforts, particularly around COVID-19 response and recovery. Trying to continue opportunities that really facilitate meaningful and consistent engagement. There's a lot of moments with which we wish we had kind of an agile, flexible community advisory group that could help, you know, direct us throughout this pandemic response. And we're actually establishing that under Scott's leadership, which will then actually fund and resource people for their contributions and provide shared capacity building opportunities and making sure that we're reaching those through programming and practices. Next slide. And then, you know, I'll be really quick on this. I know I'm over with time, but just to really say that, you know, you have this very organizational process that's happening, and then you have this, like, you know, heartbreaking, earth-shattering moment that really makes us try to rethink this work. And, you know, in response to George Floyd's murder, we had convened a couple of listening sessions, and that around trying to hear and create a space for our workforce and staff. That had been configured into a work group that's been really trying to tackle with this issue of trying to figure out how we can address, you know, anti-racism, but particularly anti-Black racism within our county. And that work group had made a decision that they really wanted to focus internally with where they feel like we have some areas for improvement. And so the work group brought a proposal to our leadership team just last week, which we have endorsed and approved, to really focus on staff recruitment and retention. One, doing an HR data analysis on our staffing configurations, but then also trying to figure out how those racial inequities might be showing up and what strategies we can do to addressing organizational culture, which is very tough in a bureaucracy, but that's a whole other session. And then really looking at personnel policies, that while, you know, we're grappling with the fact that we get policies from a centralized department like Department of Human Resources that comes to us in department land like public health, but what are our personnel policies that might be misinterpreted in practice? And so really making sure that we are, again, walking the walk of what we're saying that we want to see outside of our organization. So next slide. So the road ahead is really one, we're not out of this pandemic, but I think everybody knows that. So really sustaining our core activities with equity being core and center. You know, implementing our partner grant deliverables, which was referenced in the strategies with the grant funding. Continuing to do ongoing workforce development and capacity building. We're really kind of grappling with what is the new work that needs to be done, particularly around courageous conversations as it relates to race and how we can move that forward programmatically. Continuing to engage community in decision-making, that's a core tenet of our work, and then making sure that we identify any possibility, whether it's contracting, hiring, language, that we actually really are trying to change the different systems that make our bureaucracy very hard to advance equity. And so that will be the focus of our infrastructure grants moving forward, and will be a core part of our work in the recovery phase of this pandemic. So with that, I will pause. Sorry, I went a little bit over, and look forward to ongoing conversation.
Thank you so much, Megan. There's so much that you all are working on in LA County. And I was sharing with Megan that I actually was in the city of Long Beach in the Office of Equity when you did the listening, when you hosted a listening session. So I got to participate in those listening sessions. And I remember them being so engaging. And there were folks from all over the community that came, and that you really were able to take that feedback to inform the strategic plan, which we will share on our webpage. If you'd like to see sort of how those listening sessions inform the development of the strategic plan that Megan referenced, we'll have those resources available as well. And thank you to folks popping questions in the chat. Our team is tracking those as well. So T, I'm gonna go ahead and pull up your slides as the last presentation. And there we go. Welcome. Give me 1 second just to pull up your presentation. Great.
Well, good afternoon, or good evening from my end, but good afternoon to all of you. It's great to be with you and share a little bit about our work towards health equity practice here in Louisville, Kentucky. So we can go to the next slide. So I wanted to share a little bit about our department. So that the Center for Health Equity is part of the Louisville Metro Department of Public Health and Wellness. So our vision today is a healthy Louisville where everyone in every community thrives. And our mission as a department, it then is to achieve health equity and improve the health and well-being of all of our Louisville residents and visitors. So that's kind of what we're working towards today. Go to the next slide. So our Center for Health Equity was established in 2006, and we were under the direction of Dr. Ottawala Troutman at that time. And we understand ourselves to be the first Center for Health Equity within a municipal government in the country. So we have been this past June practicing this work for 15 years. And we were, from our outset kind of set to focus on participatory research and policy advocacy, and really working towards removing those social and economic barriers to good health. And so that has been our focus over these past 15 years. Go to the next slide. So I kind of think about our work as really, in this past 15 years, as really an evolving practice. Not always having necessarily a roadmap for us to be able to take. So we've tried on a lot of different things. So kind of at the beginning, I'll say that there was a study conducted here in Louisville to gauge the public's understanding or residents' understanding about how health happens. And so that was a cultural logic study there, the right choices versus the big picture. And the takeaway from that study was this real understanding of where our community is and decision makers are on understanding of how health happens. And a lot of that was about individual choices, was really the focus and what people were telling us about how we get to the health outcomes that we have. And so we knew that from that point that we would have to take quite a bit of time in our practice here in Louisville to really do health equity education. And so many health equity 101 have been done in this community. Lots of, at the time, what we called kind of a little bit further into that practice, health equity dialogues. So in front of anybody literally that would have us, we were in front of academic groups, elected officials, community residents, all kinds of organizations to talk about what health equity is and trying to shift this paradigm of how our community thinks about health, because we know we need everybody kind of pointed in the same direction, but we weren't talking about the same things. And so we needed to do that work and lay the groundwork here in this community. So we have done that. Some of our work at the Center for Health Equity was featured in the 2008 Unnatural Causes. So if anybody's familiar with that series, then you'll see Dr. Troutman there and some of this work. We did speaker series to kind of, again, just kind of normalizing what we're talking about. Then we tried some grassroots approaches and engagement with our community. So some of that looked like trying on to address food systems issues, healthy in a hurry corner stores, where we're trying to give technical assistance and some financial assistance to corner stores to, include some refrigeration and technical assistance to the owners to figure out how you order produce in order to carry in your stores and things like that. We've learned a lot along the way. It takes quite a bit of work and upkeep capacity to be able to manage programs like that and the finances pieces of it. We also did some community capacity building grants with organizations who could demonstrate that they were kind of working towards addressing root causes of health in some of their projects and providing technical assistance to them. As we kind of move further along into our work, we released in 2011 our first health equity report. We've released 2 more of those since then, and if this if this year can give us a break and maybe into early next year, we'll release our 4th report. The schedule has been thrown off because of the pandemic and our staff's needed to be focused elsewhere. But I encourage anyone to look at, and you can see the address here at the bottom of the slide, healthequityreport.com. So this report is known for identifying or detailing certainly the difference in life expectancy across this community from east to west Louisville. And in our 2017 report, we detail outcomes for 21 health outcomes, and then tie those for folks who read to, like, if say you're interested in asthma outcomes in our community, you could look at that and then see a few select social determinants that are tied to asthma outcomes everywhere, but in this community. So I just encourage folks to take a look at that if you have the opportunity to. We moved forward, kind of focus more on policy and practice changes as our practice has evolved here in Louisville. And so moving to thinking about, we had a policy summit. We wanted to be able to provide residents with an opportunity to inform us as a part of their local government with what are the things that we ought to be focused on. So out of that policy summit, there was a clear identification that residents wanted to be able to have more of a direct say in how local government dollars were spent. So we piloted a participatory budgeting project here out of the health department. So using some of our general fund dollars, but then also some other dollars that we had access to, including some discretionary funds that a couple of our council members, Metro Council members had to be able to pilot a project. Similar to others who have presented, we have connection to GARE and their framework. And so we've done a considerable amount of introduction to advancing racial equity trainings here in Louisville Metro government. So not just within the health department, but helping kind of guide that initiative across Louisville Metro government. And then further, as we've expanded our practice capacity, we moved into doing things like health impact assessments and building up our staff's capacity to do that. In 2017, then we also had an organizational shift. So we had traditionally or historically been a pretty small staff, sometimes 4 people under the direction of my director, Dr. Sarah Moyer. We did a realignment of the department. And so we now have, I would say, between 40 and 50 staff who fall under the Center for Health Equity branch there. And so, but we had to do some work in order to get staff who had not been initially hired under the Center for Health Equity, to get them to a place where their daily work could be transformed in that direction. So we can go to the next slide. That's just a little bit about some of our health equity reports there. You can, again, check it out at the link. And then the next slide. What we did when we had to make that, we made that alignment change within our department, we created 2 things: root cause teams, and then we also created some skill set labs. So trying to bring together a clear, explicit focus on root causes for our staff, especially those who had not historically been necessarily working explicitly in that vein. So we developed a work plan that we went over the many months, probably 7 or 8 months it took us to go through this process. There were readings that our staff did. We even practiced, because it's important to be able to deliver this message of health equity. So in some of our gatherings, our staff would take turns doing elevator speeches about health equity so that they can talk more confidently about what we are aiming to do in our community. And then they were responsible for doing some research on various root causes, coming up with briefs on those and action plans around those issues. So this was coupled with the skill set labs around policy development and analysis, data analysis, strategic partnerships, and in community engagement as well. So staff are participating in both of these groups. And if we go to the next slide, you might see there kind of the composition of a root cause team. So you have people from all of those different skill set labs represented in a root cause team. And then they're all kind of learning together and then doing some planning and taking action together. Okay, we could go to our next slide, I think. This is just a little bit about kind of where we are today. Some of that looks like, again, doing health impact assessments. It's really interesting for us. Louisville in Kentucky is kind of like, if you're familiar, is kind of like a Austin in Texas kind of situation. So sometimes we are in a position to maybe provide some of the research and some of the narrative and framing for some policies that are, some legislation that maybe is being considered at the state level. Because we have, like many others, some issues with pre-exemption, preemption and things like that. So we are trying to inform some of what's happening at the state level as well through our health impact assessment process, because Louisville itself may be in a different place than where the rest of the state is. So these are just some examples of some of the health impact assessment work that we have done at this point. I will say in the past almost 2 years here, I think because of where we have been in terms of our organization piece, we were able to inform, for those who are familiar with, incident command structure, like that was stood up as a part of our COVID response here. We incorporated an equity officer into that structure as a way of trying to inform what was happening from an overall systems like community-wide response effort during COVID. And then many of our Center for Health Equity staff being a part of that incident management team, especially in the planning department. So being able to identify what some of the future needs were from the beginning of the pandemic, really all the way through. We're actually still internally in our health department utilizing the incident management team structure at this point. So to be able to have staff who are knowledgeable about with an equity framework embedded was important for us, I think, in some of our COVID-19 response. I will leave that there.
Oh my gosh, thank you so much, T. A big round of applause for all of our panelists. I know Louisville has been such a leader in this work for so many of us. I remember looking to all of you as a model when we were launching the Office of Equity in Long Beach. And so thank you so much for your leadership in this work. I saw a lot of folks in the chat just loving the idea of root cause teams and the model that you're employing there. That's so exciting. So I know we are going to open it up to questions. I believe Anna's been monitoring the questions as they come in the chat. So if you have questions, if you'd like to ask a question verbally, you can also use the raise the hand function if you'd prefer that than putting the question in the chat. So Anna, do you want to kick it off?
Sure thing. Thank you all. I was furiously taking notes and I have my own questions queued up as well. But we'll start with one of the questions that Michael put into the chat. And I'm going to paraphrase a little bit. And Michael, if you'd like to come off of mute and also ask your question as well, you're more than welcome to do so. But it's, other than reporting, talking about equity officers and departments, which are essentially process indicators that you've kind of achieved this milestone and you're making progress in that way. It seems that we're also talking about the need to develop some outcome indicators for equity as well. And so how do you all think about measuring equity and the outcomes related to what you're working towards? And what are your benchmarks that you're thinking about in the work that you're doing? And whoever wants to jump in and answer this one first.
Well, I can share, I will say, so many of like all of us in public health departments have community health improvement plans. I will say that in our CHIP process previously, we would identify like, okay, here's the rate of diabetes in our community, and we would like to see a reduction by this much over the next 5 years, right? And it isn't that that's not important, but we have shifted at this point for our Healthy Louisville 2025 is what we call our current community health improvement plan. We have really shifted to the goals that we are working towards are explicitly focused on the root causes of health. So it's either about the built environment, it's about environmental equity. We have one goal that's about our connection to the school system and provision of some health service there. And then one around housing, and that work has evolved into really looking at evictions in our community. So I will say that we've just made a shift in this. We say, okay, if we really want to focus on social determinants of health, then maybe those are the goals and the indicators that we need to be looking at. Instead of saying, in reality, how much our diabetes rate is going to drop a significant or noticeable way in 5 years may be challenging for us to really measure for lots of reasons.
Yeah, I've been trying to grasp for this. I asked the question, and certainly, if you look at benchmarks or whatever, I mean, if you look at equity of anything in the South, it's completely different than that in California, and in terms of measurement, et cetera, and in terms of what we can control. I mean, we're looking at equity within our departments of public health, and our policies, racially, sexually, gender-wise equal. Is there equity in our policies? How do we measure that? I mean, is it based on, does our percentage of racial employment better than our endemic natural rate? Like we have 8.9% African American. Are we going for equity in terms of reflecting that, or equal Black, African American, Latinx, white, male, female? So I think it would be good to look at and think about outcomes in terms of being able to measure and say, hey, we're getting there. I can see, our county was the first one to declare racism as a public health crisis, but we've got an equity group, but it's just like, how do we get there? It's rather than just doing it.
You pose a great question, Michael. I would say that this is an area that's emerging for us. So I think to your comment, I think, it is kind of like, what is the North Star in looking at equity metrics, right? Do we want the diversity of our leadership to look like the population equally? And I think there's not a clear answer for that. And, I've done this in nonprofit spaces around data analysis, and then trying to do this within government. I think another way that we're tackling that equity question, one, is really diving more closely into results-based accountability. We have quality improvement specialists across the entire department, not for every program, but pretty well represented. And it's a way of thinking through data and taking action that really measures the quality of life in communities and cities, or whatever your jurisdiction of authority is. And so one of our learning journeys pre-pandemic was how to move beyond widgets. How many people did you serve? Well, how do you get to that quality question around, did that direct service of giving the shot versus how are we really reaching, the vaccination rates that we want for the flu vaccine, before then. So that's been a process that we've been working with our quality improvement folks. I think the other thing that we've been doing is embedding those type of metrics into our budgets. So they do a budget narrative every year with for each fiscal year. And those things we had to actually go through a learning process with our programs around not just widgets, like kind of what are the things that really speak to that impact. And then I think similar to what T had noted, this is more of a countywide effort under the anti-racism, diversity, and inclusion effort. But they've identified a set of North Star outcomes that really have identified that if we were to address these outcomes, and they go from stable employment to infant mortality to federal poverty level to some educational outcomes and some contributing factors, but it identified some of these outcomes as ones that completely can change your trajectory in life for a whole host of other different outcomes across the entire county. And that's very fresh. It's like months old. And I think us as departments are trying to grapple with how that could actually move us towards some of these anti-racism metrics. But I think to Michael's, I think the heart of the question, I think that there is, I think it depends on kind of the program that we're talking about and what we're trying to shift. And what is the end goal? What is that particular North Star for that program? And then how do you actually move to data that's not just widget counting that would allow us to really address our progress?
I agree. That's both great answers. And I think probably you have to start with process outcomes first, and maybe just developing that lens, the equity lens, and does this fit? Does this filter through that way? And then, but I think that we need to look at outcomes too, however we measure them. That's I'm just a data kind of guy anyway. So.
I just would like to add that in addition to what's been shared by Megan and T, something that we've also are examining here at Public Health is really going from transactional to transformational, and that it's going to take time. And sometimes the process is also an outcome. So really being able to measure that as well. Are we looking at performance measures within the organization? Are we looking at population level indicators, which take about 10 years to shift? And what part of it do we own? And how do we do that in collaboration? There are so many different dashboards and resources within Public Health. We are very data heavy. How much of that is accessible? Who is tracking? Who is owning the CHA and the CHIP and all these subpopulation health assessments that we do time and time again, where a lot of our communities are quite frankly fatigued with all this assessing that we do? Like, where's the action? Where's the transformation in our systems? And how do we track and monitor that? And relationship building is key to that, whether it's inside of the system or outside of the system, to move systems. So I think it's an and I think it's something that it's taken us generations to get here, and it's going to take us generations to get out. And I think the work that we are doing is foundational in really shifting systems and structures. And part of that is tracking how much is being done, and are we truly doing this in collaboration and in partnership with the communities that we're trying to positively impact through our efforts and through our work.
It's really just, here resonating with what you said at the end, Analilia, about, moving from transactional to transformational, and, it took us generations to get in and generations to get out. I think that there's just so much here, and I'm seeing a lot in the chat about, from folks about, the process is part of the outcome and the process is. So I think that there's a lot that people are kind of like really picking up from this as well. I also saw another question, so going to shift a little bit away from this, from Dana about leadership. And Dana, would you like to ask your question to the panelists?
Sorry about that. Sure. I think my question is really just about, what I heard from all three panelists, which was just really great work being done. And I'm curious, for those that are wanting to scale their work, but we see, leadership that is resistant, how this work is then able to move forward.
And can I hop in? Because I had a similar question, but building leadership in this case could be departmental, or it could be boards or councils. I think a lot of folks are also curious, how do you move your boards or your councils along with you in this work?
Yeah, I mean, it's a tough question. And I would say that in any place I've been able to do this in Boston, I've been able to do this in LA. And I would say that, the political will has been very helpful to move things forward. And I think we've really benefited, one, from a pretty progressive board that is, unanimously adopted a lot of these requests. And, we've really benefited greatly from Dr. Furr's leadership. And so there was a lot of, I think internal leadership in trying to grapple with this work before Dr. Furr's arrival. And I think her creating that mandate really kind of helped to advance things. But I would say that still, even in that, we're the divide by 5, I would say that COVID in particular actually has presented a unique opportunity for us to really look at the disparate impact of COVID on particular populations. And I think it was undoubtable, it was indisputable of the differences between, Black, Latinx, Pacific Islander, and, poorer communities or communities with less resources. And so, I think the strategy has been for us is to always lead with the data. I think that particularly for our electeds, I think making sure that our public facing documents, I think reflect and elevate those inequities, making sure that we're communicating in that regard. I think that, we've been able within the board is also to talk about inequities within your particular district. So that while you're kind of looking, I'm in a more affluent, district, but then there are pockets. And so being able to have those conversations around the infrastructure distinctions, particularly in this pandemic, around, outlets for being able to do testing or being able to do, vaccination outreach work. And so I have found, kind of that, pragmatic approach to be able to been effective, particularly with those most resistant offices. And I would say that the divide by 5 has gotten a lot harder in this current state of affairs, just in light of we're seeing communities are looking very, very differently impacted. And so I think that that's really helped to address this issue. And so I think the other strategy is I think you just capitalize on those small wins. Maybe it's a topical issue, right? We're not going to tackle all of the equity issues, but right now we'll talk about violence. All right, now we'll talk about the STD, impacts, or we'll talk about, COVID in that instance. And I think being able for them to see the benefits within a particular topic, I think is able to kind of elevate an interest in other issues more broadly.
T or Analilia, any strategies for moving leadership along with you, especially if there is some resistance?
Just want to echo what Megan just shared. Across our county, there is a lot of political will and internal leadership, but it does take one person at a time. And I feel like the messenger matters. Who is the messenger in this work, and also operationalizing an inside-outside strategy. I think just in doing community engagement, where people always say, well, how do you operationalize racial equity? How do you apply a racial equity lens, which has become such a buzzword? Well, data is really key to that. And community engagement is really key to that. Partnerships, I want to echo, more than outreach. It's just the partnerships that you have. And I think being really transparent with your partners about, I am a government employee. And I think being honest and transparent of your own opportunities and limitations as well. And recognizing that community engagement and partnerships are really key in doing this work. But the work that I've done at Public Health started in 2016, and I feel like it's been one person at a time in having those conversations, very courageous and difficult conversations to have. But I think leadership is essential, and also not just within the system, but actually in community as well. Is a super critical piece of this, because I think there's tremendous power in community in doing this work. But I do have to say that I'm speaking from a local context. I'm speaking from a county where there is a lot of political will. We established a promotor program, community outreach, community navigators and community health workers during the pandemic that were front and center partners with us, that were getting paid. So I have to say that I speak from that place, and I want to just name that every place is very different. And I think understanding and knowing the local nuances, the local political landscape, and doing this work and the political will is really key to this. And your partners, who are your allies, and doing some power mapping. That is something that I do in community with our community partners. So power mapping is really key to this work. So a lot of the community organizing principles that I use, that are implemented in partnership and learned about in community, have really been front and center for a lot of the work that I continue to do. I'm just organizing from within now. I'm organizing from within a system to disrupt a system.
Yeah, the only thing I was going to add was, I think maybe Megan kind of getting a little bit towards in the chat. What I was thinking is, do you know what the source, is there an outright equity thumbs down or is it just that, hey, I could be supportive of this, but I am not sure how from your leadership, right? Like, is it like a lack of expertise in that area? And I think all of us know what it's like to engage with leadership who maybe don't have a particular expertise, and therefore they kind of maybe steer away from moving in that direction because they want to be seen as the expert. I would say, right, like in my situation, I have a director who has said, we absolutely have to do this. And so that's why we've had the kind of expansion of the center under her leadership. And also, she is terribly smart, but also she is not going to identify herself as an equity expert. So she has said, okay, hey, this is where I need your leadership in this area, and let's do it. So I guess it's one thing if you have outright resistance or opposition to equity, as opposed to, yes, but I don't know how, and how are we going to figure out how to do this in our department? I think that dictates maybe the strategy there.
So there was a lot, and I'm realizing that looking at the time, we have time for one more question. But what I picked up a lot in these last couple of comments is about this inside outside strategy, organizing internally to really, what Analilia said, disrupt a system. And I was thinking about how, some of you had talked about you're creating these teams that are cross-departmental, that are bringing in other branches of government or providing training. And I'm curious if you can all speak a little more about how you get other departments on board, particularly given that they may not have, the time or the resources to extend their staff in these ways. And how do you elevate this as really important to these other departments and getting the buy-in? So if you could talk a little bit more about, maybe what does that little internal strategy look like, and how do you really bring in others? And T, I'm wondering, because you talked about the root cause teams, if you could maybe kick us off with this question, if you could say a little bit more about how you kind of brought others in.
Yeah, I think some of this kind of really probably started before, I would say, under a previous department director, with some of our health and all policies work, right? And she, for a time while she was here at the department, was kind of bringing together directors from across Louisville metro government, which has around 24 to 26 offices or departments, right? So she's bringing together these department heads to talk about health and all policies and what that means. So I think that that's one way that you can go about doing that. There have been some, though, where I'll say I had a conversation earlier today where all of us are talking about how we might use American Rescue Plan dollars. If your city is receiving some of those, that's a big discussion right now. And with all the federal restrictions on how that can be used. But, I will say I had a conversation earlier today with a colleague over at the Parks Department, who they have really been working towards the vision of, it's called the Shawnee Outdoor Learning Center, that this vision of the realization of that and we were talking today, like trying to organize together to be like, okay, what angle are you working to? Because I fully support, I think it was an incredible investment in our community if we move forward this project and providing educational opportunity, but leisure opportunity in one of our parks here, and in a community that has really been not invested in the same way in terms of leisure and outdoor activities. And also then some environmental cleanup that's at a neighboring park. So, him and I discussing today, okay, so who are we working on communicating inside, right? Who are we talking to? What Metro Council members maybe, because they're a part of the approval process for this. How are we doing that? And I think that's like, okay, maintaining that connection for years at this point, him and I, on these particular projects, and trying to recognize where there's opportunities for us to perhaps advance it. And we feel like we're at a critical moment right now of, are we going to be able to push the decision makers inside Metro government and our legislative body, the Metro Council, to see this as these two projects as something that are worthwhile in investing with these, once in a lifetime dollars that we're going to get right now. So I think it's about, how do we maintain that? And nobody, we have to hold ourselves responsible to that. Nobody's telling me and him over these past decade, hey, stay in contact with each other, right? We're that's a commitment that we're having over this past decade in order to try to work on some initiatives together. Because, hey, we've got one more year left of the mayor that's in office right now, and they'll change over. Metro Council members change. But, hopefully me and him will still be here if we want to be, right? So I think it's about trying to maintain those relationships at those who are not maybe always in the changeover positions like that.
Great. And Analilia or Megan, I just want to open it up if you have any other comments on this, inside strategy. How do you ensure or bring in other departments that may not have this as a priority into these cross-departmental teams or work that you're doing?
And just my colleague, David Cardenas is here. Hey, David. And saying we're just sharing our struggles with you in ARP in LA. But, I would say that I remind ourselves that public health has always been the convener. We're pretty effective at bringing folks into the room. I think our challenge, the challenge often comes in trying to change the way that we do work, and doing change is hard. Sometimes. And so I think being able to, we've really tried to make things as easy as possible. So if we're trying to tackle contracting, bring our contracting team into the room and working with the CEO directly and addressing kind of what are the pauses and concerns, being able to, I think, establish shared commitments of what really is feasible. We're similarly going through, processes with Public Works and how do we really maximize land use decisions and the way that they do this and the way that their funding is set up. And so one is trying to understand a shared language about kind of how they operate and do things. And then what are the choice points that we can make together? And then I would, just say that the relationships are really important, and staffing changes, all the time, elected change all the time, to all the points that T said. And so making sure that there's kind of a consistent plan so that those agreements don't get lost with those transitions. And that's really hard. So good record keeping is really important. And I think being able just to, sometimes small changes. The master agreement thing feels really small, but it was huge. We had to meet with board deputies over it. We had to really justify it. This is a pilot. Don't get committed. I think all of those things of trying to find things that allow people the comfort, because we as government, we don't feel like we can fail, but that's where innovation happens. And so we have to try some things, and figure out how it works. And so I think the extent with which we can show where it's possible, lifting up other jurisdictions always helps. So shout out to everyone here, because your examples help us make things easier more locally. And then being able to make sure that where we see barriers, we provide kind of the ways we can support and find a path through.
And I just want to add in closing, echo what has been shared. I'm taking a lot of notes as well. Pre-COVID, I felt like it took a lot more conversation, come join me, let's have a cup of coffee, let's talk about the work, let me tell you what public health is doing. And, we beginning to change the way we engage with community, the way we partner with community. I have to say that in the moment that we find ourselves right now, it is the demand that just far exceeds the capacity that we have. I'm working with county librarians right now. I'm training elected officials and their offices. I'm working with so many people who feel a sense of urgency all of a sudden. And that's another thing. It's that sense of urgency of the train me, and really echoing that this goes beyond a training. This really goes beyond words of support and words of commitment on your website. on your strategic plan, how are you going to operationalize and have fidelity to the work and integrity and impact and the responsibility that we have to our inside community, which is our workforce, and our outside community, which are the residents of our county. So I think for me right now is really going beyond, I'm saying no to anyone that invites me to just give a 10-minute talk. It's like, what will you do beyond that? What is your commitment beyond that? And where's the leadership, both non-traditional and traditional leaders in your organization? And how will you hold this work and to fidelity? And I think that's something that I'm really holding true right now, because I've seen an outpouring of requests for anything with the word equity in it. I don't know if any of you feel this way, but you get invited to that meeting, you get invited to that talk. And this, with the exception of this one, I think that it's really important, how we show up in these spaces and how we also protect our time as leaders in this work, and how we protect our health and our well-being as doing, as we, this work is difficult, and that's for another session. But I think that's another critical thing to lift up, especially as a person of color doing this work, as a woman of color doing this work, and trying to transform systems and really drive an anti-racist agenda from within government.
Oh my gosh. Wow. Thank you all so much. Another big round of applause. This has been incredible. I know we didn't get to everybody's questions, but we will share the recording. We'll share the slides. I know there's been a lot of resources shared in the chat. We'll be sure that those go up on our collaborative webpage. So if you want to dive deeper into a lot of these amazing tools and approaches that have been shared today, you can do so in your equity change teams. Just a huge thank you, not just for joining us today, but all of you are such incredible leaders in this work. I know we all look to all of you in your work and incorporate that into our own practice. So we're so grateful for all of your work that you're doing, your bravery in this work, and for just being such amazing leaders. So thank you for joining us today. Really and sincerely, we are excited to continue to be in partnership with all of you moving forward.